שלום לכולם, תודה רבה לפרופסור נתן שערי שלא צריך להציג אותו. אני רק רוצה לספר שתמיד מרגש אותי לראות שבפרקים של הספר לכאורה המתחרה, הטקסטבוק המתחרה בברוארה, יש פרקים של פרופסור שערי, וזה מעיד בעיניי גם על המקצוע ועל הקשר המיוחד שיש בין הרופאים והאחיות ואנשי צוות במקצוע שלנו. וזו הזדמנות ממש לשמוע מהמקור על הנושא של Palliative sedation. תודה פרופסור שאתה איתנו.
Okay, is everyone reasonably comfortable with me speaking in English if I speak slowly?
Ahead.
Okay, I'm going to, the reason I'm calling this a 30-year perspective on palliative sedation, because in the coming months is the 30-year anniversary of the paper that I wrote with Russell Portnoy that came out in the summer of 1994, which was really the first review on the sedation, on the use of sedation in the management of refractory symptoms, published in the Journal of Palliative Care as in 1994. And my background to that actually starts 4 years earlier, when I was a trainee oncologist at the Alfred Hospital in Melbourne, and the former chief nurse of the nursing school was dying, and she was in severe distress with pain and really overwhelming death anxiety, which she described as an intolerable situation. Euthanasia and assisted suicide were absolutely illegal in Australia, although assisted suicide, they've actually both subsequently been legalized then. And her closest friend, a woman called Anne Davis, and this is Anne in the top right-hand side, flew from the United States to be with her. And Anne was a professor of nursing ethics, and below is a copy of her book. We initially tried to provide comfort with her with morphine, psychiatric assistance and chaplaincy, and she remained very distressed, and we decided that the only way we could provide adequate relief for her was to allow her to sleep until she died. This was discussed with her family, and her treating physicians and nurses. And all agreed, and she was started on a midazolam infusion that was titrated enough to keep her comfortable, and she died several days later. And this for me was my personal first experience with the use of sedation in this setting. Skip forward a couple of years, and when there was the peak of the controversy about Kevorkian, and this is a picture of Dr. Jack Kevorkian with his assisted suicide machine, where a patient would pull a lever and then could essentially be self-injected with a range of several medications to kill them relatively quickly. And at the annual assembly of the American Association of Hospice and Palliative Care, they were debating what should be their opinion regarding assisted suicide and euthanasia. And in the discussion was seen very much as an either-or option. Either, you'd have a situation where palliative care is sometimes not working adequately, or an option of euthanasia. And I raised the issue then based on my experience in Australia, the option of sedation for refractory symptoms is an option which can sometimes provide adequate relief without needing to resort to euthanasia. And this was a very novel opinion to many of the people that were present there, and it sort of triggered me to try to formalize my thoughts about it, and that's what led to the 1994 paper. Now, subsequently, there was and this is now after the publication of that paper, there was a suit in the United States as to whether assisted suicide should be a constitutional right. So should patients have the right to say that they don't want to live any longer? Patients with far advanced cancer or other causes of intractable suffering, and the Supreme Court ruled that that there is no right to assisted suicide. You can't make a claim on a doctor that they must assist in the death of patients, but they said that palliative sedation, and this was after the publication of our paper, is a patient right. That it offers patients the chance to have adequate relief from suffering without needing to invoke issues of either killing patients or assisting patients to kill themselves. So that's a bit of background. So I'll just go through what we're going to cover briefly in the next 40 minutes. So we're going to talk about some basic concepts of what is a refractory symptom, how is it different from a difficult symptom, and how does this relate to goals of care. We'll talk about the ethics of sedations, clinical practice, and how things can go wrong. We've already talked about the history part. So palliative sedation, and there's some key words here, I'll emphasize them, is the use of proportionate sedation, and with an emphasis on proportionate, as a measure of last resort, used at the end of life to provide adequate relief of severe and refractory symptoms. The aim is to relieve the burden of otherwise intolerable suffering for terminal patients in a manner that preserves the moral sensibilities of the patient, the medical profession involved in the care, and concerned family and friends. And the idea is that although some people may be quite comfortable with assisted suicide or euthanasia, many people are not. And palliative sedation really skirts that issue. It involves,
Nathan?
Yeah.
Can I ask a question?
Sure.
Can you relate to the new position paper of the EAPC regarding the definition of
So
palliative sedation? Because
their new definition highlights this issue of proportionate sedation.
But they don't relate to the end of life, which is, to me, a bit problematic.
Yeah, so although it's not related to in the definition, in the selection of patients, it is still for the most part looking at the end of life. And there's really no, unlike the situation with euthanasia in Belgium, where they're now advocating it for psychiatric disease in the absence of people being in a life-threatening situation. I think that in the world of palliative care, it is still, in general, being reserved for patients approaching, at the end of life or nearing the end of life. And in the discussions around the new paper, there was no real intention to be bringing it forward to earlier stages. It involves the administration of sedative medicines in a monitored setting to induce a state of decreased awareness or absent awareness. It is very much predicated around the idea of what is a refractory symptom. And we'll discuss also how a refractory symptom is just different from a difficult symptom. A refractory symptom is defined as a symptom causing intolerable suffering, which cannot be adequately controlled by therapies that don't seriously compromise consciousness. And there are three diagnostic criteria, and those are that further invasive or non-invasive interventions are either one, incapable of providing adequate relief, or if they are associated with excessive and intolerable acute or chronic adverse effects, or thirdly, if other approaches are unlikely to provide adequate relief within a tolerable time frame. And I'll illustrate this with an example. That was the second one. We had looked after an elderly man who had a metastatic cancer of the prostate with a large paravertebral mass extending into through the intervertebral foramina, causing a severe spinal cord compression at multiple levels. And the option that was put to him was that he could have a trial of a nerve root block with phenol. And the anesthesiologist explained to them that there's a good chance of providing relief, but he should also understand that he may come out of it paraplegic. And for him, the issue of paraplegia was an intolerable chronic adverse effect that he was not prepared to consider. And in the absence of other options, he chose the path of being sedated rather than having a trial at a phenol block. Unlikely to provide relief within a tolerable time frame when someone is in acute dyspnea with multiple metastases at the end of life, or possibly after a major pulmonary embolus. There's not time to do other things. You need something which is going to get them comfortable very, very rapidly. The implication of a symptom being refractory is that the severe suffering will not be relieved unless the patient is sedated. The consequences of refractory distress are that it undermines the quality of life, it leads to despair, and it will commonly lead to requests for euthanasia or assisted suicide. And these can be things that can happen for the patient, the family, and the healthcare providers. The most common symptoms causing refractory distress at the end of life are dyspnea, delirium, and pain, pretty much in that order. I'll talk a little bit of goals of care because these are an important concept here. The three goals of care at any time can be either prolongation of survival, optimization of comfort, and optimization of function. And in the early stage of a disease trajectory, generally survival, it takes priority over function and comfort. That's to say that the patient who again, a dramatic example would be a patient who has a sarcoma involving their leg may choose to have an amputation which will compromise their function and comfort to give them a chance of long-term survival. And obviously in that sort of situation, sedation is not appropriate. But at the far extreme of the end of life, as patients' conditions are deteriorating, the priorities change. And it is clearly possible that the patient will consider their comfort more important than their interactional function, and more important than how long they're going to live out the rest of their life. And this is the situation where sedation may be appropriate. From a moral perspective, the issue is an issue of non-maleficence, that clinicians want to avoid therapies that provide inadequate relief or excessive side effects, but on the other hand, you also want to avoid sacrificing conscious function when there are viable options that are unexplored. From a clinical perspective, there is a differential diagnosis, and the differential diagnosis is a difficult symptom. And a difficult symptom could potentially respond within a tolerable time frame with adequate relief and preserved consciousness without excessive side effects. And this is the importance of careful patient assessment and involving palliative care experts, because what may seem refractory to a non-expert may not be refractory to someone who is very expert in palliative care, and thus the need for palliative care experts and consulting with people if you're a non-expert, and the role of multidisciplinary evaluation of patients to see, well, have we really explored all the options that may potentially help them? A common question which is asked, and this is a very important ethical distinction, is how do you distinguish palliative sedation from slow euthanasia? Well, firstly, from point of view of definition, euthanasia is defined as the deliberate termination of life of a patient by active intervention at the request of the patient. And palliative sedation is different in three ways. The intent of palliative sedation is to provide symptom relief, and it is not expressly to end the life of the patient. In terms of proportionality, sedation needs to be proportionate to the prevailing symptom, its severity, and the prevailing goals of care. So for some patients, they may need a relatively light sedation to provide adequate relief, and to some patients will need much deeper sedation. And we're always trying to use the least amount of sedation possible to provide adequate relief. Euthanasia is all or none. There's no issue of proportionality. And in terms of the definition of success, euthanasia the success of palliative sedation is defined by patient comfort. It's not defined by the death of the patient. And we not infrequently have the situation where the patient is comfortable, but the family is distressed. Because this situation where the patient is with them but not with them, that they are alive, they're comfortable, but they're no longer interactional, that's a very difficult time often for the family members until the patient succumbs. But if the patient is still alive, that does not mean that, and obviously with euthanasia, if the patient's still alive, something has gone wrong. In the past, people tried to justify palliative sedation using the so-called principle of double effect, which saying you can dichotomize good outcomes from bad outcomes, and so if you've got good intentions, you can justify bad outcomes. But when someone dies after a long and difficult illness, Michael, what do you say to the family?
I'm embarrassed to try and give you an answer, but someone dies after a long illness. Baruch Dayana Emet, and they're out of their misery, and it's no longer suffering.
So Baruch Dayana Emet is actually a wonderful Jewish prayer which acknowledges that death is not always bad.
Yeah.
And so there's something disingenuous in trying to dichotomize death as always a bad outcome. And that lacks integrity. So we've seen away from the principle of double effect, and the issues are that uncontrolled suffering at the end of life constitutes a critical situation. Palliative sedation constitutes a proportionate and effective response to suffering within accepted medical guidelines, and it's supported by principles of patient autonomy and self-determination. As a goal-appropriate therapy in the setting of a compelling medical indication, there's nothing distinct about palliative sedation as a new ethical problem. And really it is not different from any other high-risk intervention in the setting of compelling indications where you have an appropriate indication. And finally, that it requires consent. And when I have a patient, say, who's got progressive lung metastases, I will often raise with them about, these sort of patients are often very concerned about how they're going to end their lives and how they're going to end their lives with a sense of suffocation. And I say, look, we are committed to make sure that you'll be comfortable. And even if it's the only way we can ultimately ensure that you're comfortable is in the most extreme situation, needing to make you sleepy so you're not feeling it, is that okay with you? And to have that discussion in advance. So where possible, I try to have an advanced directive authorizing palliative sedation. And in other situations, if that has not been done in advance, at the time, they discuss with the patient, and if the patient's not able to participate in the discussion with their surrogate. And I have patients who say, not now. I had a dramatic patient once, a young woman who said, look, I'm really very miserable with my pain, but I have unfinished issues with my mother, who was a Holocaust survivor, and we need to talk these out before I can go to, before I can use this option to get me more comfortable. I will deal with my pain without being sedated until then, and I'll tell you when I'm ready. Another common question that arises is, does palliative sedation shorten life? And there have been multiple cohort studies looking at patients in hospices that have and have not needed sedation, which found really no difference in their overall duration of survival. Now, that's not to say the patients may not aspirate or that they may be given an overdose. Those risks involved about overall, this is not about shortening people's lives. This is about ensuring comfort. And interestingly, when palliative sedation was used with patients weaned from ventilators or not used in an intensive care setting, the patients who were sedated survived longer than those who were not. So, this is a sort of conversation that I'll often have with patients. I need you to know that maintaining your comfort and dignity at all times is critically important to me. It's important to me that when the time comes that you'll be comfortable and not suffering, and I'll do everything in my power to ensure that. Sometimes in a worst case scenario, the only way I can be sure the patients are comfortable is to use sedation to ensure that they're not suffering. And I want you to know if that situation ever occurs and that you're not able to communicate your preferences, I need to know that I have your permission in advance. And that's something which can be documented, in advance. When there's a process of consent, we talk about what's the general condition, what's causing the distress, review what treatments have not been worked, what the prognosis is, what other options we could have considered, why they may or may not work, the rationale and aims, explaining that we'll use the least amount of sedation possible to get them comfortable. I'll talk a little bit about patient monitoring, and this becomes important when people want respite sedation or temporary sedation just to take a break. Are there any alternatives to be considered? And what are the anticipated effects? Anticipated in terms of reduction of conscious level, the anticipated effects in terms of the ability to eat, drink, and communicate, and what are the potential risks? And there are risks, and the risks are a small risk of paradoxical agitation, but sometimes in trying to find the right dose, it can take a little bit of time. There's a small risk of aspiration, and there's always a possibility that the dose may be too high and it may hasten their death. For patients who lack decisional capacity, where possible, if they have an advanced directive, that will be followed. If they don't have an advanced directive, then we're trying to seek consent from a legally recognized proxy. And when the patient is a child, you need the consent of a parent or guardian. And with older children, you need to talk with them as well to have their agreement or assent. You don't do things to older children just at the behest of their parents if they're not agreeing as well. When there's no advance directive and there's no proxy, what do you do? Well, so for terminally ill patients who are actively dying and in severe distress, comfort measures should be considered the default. They should be considered the standard of care, and that would be considered the default for treatment decisions. When we use palliative sedation, overwhelmingly the most commonly used drug is to use midazolam because it works rapidly. It's fairly easy to titrate. It can be given parenterally, the subcutaneously, or intravenously. But there are a range of alternatives such as lorazepam, nosinam, which is levomepromazine, chlorpromazine. We have some experience with phenobarbital for patients who got paradoxical agitation with midazolam. And in some places in the world, people have used propofol, although in Israel, propofol requires anesthetic supervision. So we've not used that here. Palliative sedation can be done either in an inpatient or in the home. The routes of administration depend on the drug that you're using. Can be intravenous, subcutaneous, IN, rectal, and we would initially do a dose titration fairly rapidly to achieve adequate relief. So if I'm using midazolam, that may be using 2.5 milligrams every 10 minutes as a bolus to get adequate relief. And then once the patient is adequately relieved, start a continual infusion. On a personal level, I've always used an infusion pump in order to be able to adjust the rate easily. I'm aware that in home care settings, in many practices, they just use midazolam over a 24-hour infusion, either 1 or 2 milligrams, or if you say 25 or 50 milligrams as a 24-hour infusion, which I'm told has been working. But in a setting where it's a home infusion, it would be very easy for someone just to open that up wide and run in a faster dose than is needed. And we would always have available a PRN rescue dose, an as needed rescue dose in case the sedation is not adequate, and again with the readiness to titrate. We aim for the least, the lowest level of sedation necessary to provide adequate relief. And if mild sedation isn't working, obviously we're going to go to deeper levels of sedation. But when you have a severely distressed patient in a catastrophic event, then we would go to rapid deep sedation. The term, the use of deep sedation until the end of life, is something which is a term that the updated guidelines do not encourage, because they emphasize the issue of proportionality at all times. Now, when a patient is imminently dying, I'm not interested in heart rate, blood pressure, or temperature, and the only critical parameters are related to comfort. If, however, the patient is not imminently dying, and say this is for respite sedation, just to give patient a time out, the aim is to preserve their physiological stability so they can subsequently wake up. And in that situation, we are going to be doing vital signs monitoring. And if we see life-threatening obtundation, we'll lower the treatment dose, and in rare occasions, we've needed to use flumazenil. Flumazenil is like naloxone for benzodiazepines. And like naloxone, one needs to remember that it has a short half-life. And patients who are very deeply sedated, who've needed flumazenil, if you give them one dose, they wake up and you walk away, they may fall back asleep again. And if they've been having, say, midazolam over a period of time beforehand, because midazolam is lipophilic, people build up stores of it in their fat, which continues to gradually ooze out. So they may need a continuous infusion of flumazenil. I mentioned respite sedation, and this is the use of a planned temporary sedation where you're trying to give people essentially a timeout. This is used particularly when the refractory symptom is a existential or psychological distress, and this enables the opportunity to reevaluate the patient's condition and preferences after they've had some time out. The risk with the respite sedation is that patients don't always wake up well, or that the symptoms may reoccur, and there's also a risk that death may intervene, and this is why we're monitoring vital signs. In the early years of the literature about palliative sedation, some people were saying that automatically palliative sedation, you stop hydration as well. And I would urge people not to do that. This is issues of hydration and nutrition are separate distinctions independent of the palliative sedation. Although the sedation is clearly beneficent in terms of providing relief of intolerable suffering, the beneficence of withdrawal of nutrition and hydration is not self-evident, and by some people it may be perceived as harmful. There's few data supporting the clinical benefit of hydration or nutrition in imminently dying patients. It doesn't prolong life and it doesn't make patients more comfortable. But some people see, particularly in Jewish law, see hydration in particular as being a very fundamental support. And certainly our practice is we keep everyone hydrated, because the last thing that I need is to have someone to say that, the Dr. Cherney at Shari Tzedek is sedating patients and not hydrating them, and he's dehydrating them to death. And so it is important for me to be squeaky clean. So around the world, options and practices vary, reflecting the heterogeneity of attitudes of the involved clinicians, ethicists, patients, families, and the local norms. Where there are religious or culturally based reservations regarding the discontinuation of nutrition and hydration, these can be maintained unless there is evidence that they're causing direct patient harm. So if I have a patient with massive edema who's third spacing, that's a situation where the hydration is harming rather than helping. And in that situation, I would stop it. But otherwise, I would maintain a low level of hydration. Again, more for as much as anything for appearances. That appearances matter. Administration of previous medications. Medications that are no longer consistent to the goals of care can be discontinued. There are some medicines that you can't discontinue abruptly because of potential withdrawal responses. If the patients are receiving pain medicines, I will generally leave the pain medicines along with the sedation. Sedation for refractory existential or psychological distress. This is different to sedation for pain, agitated delirium, and dyspnea, and it's different for several reasons. Firstly, there's a high degree of subjectivity as to what regarding existential distress and psychological distress. Secondly, they can be very, the severity can be very dynamic. The patients desire, the degree of existential distress can fluctuate quite a lot. And it's very common for people to say, if I get to this or this situation, that's it, I wouldn't want to live anymore. But then when they actually get there, they say, you know what, I can deal with this, but if then they essentially redraw the line in the sand further along. The standard treatment approaches for psychological distress and existential distress don't have a high degree of morbidity. They're not difficult in themselves. And finally, and this is probably most difficult, is that the presence of these symptoms don't necessarily indicate a far advanced state of physiological deterioration. And this goes back to the point that Batsheva was raising earlier about what about the patient who's got relatively early stage disease with severe existential distress, and would you or refractory existential distress, and would you sedate a patient in that situation? And I would not, and I don't think that this is the aim of the guidelines. Things can go wrong. And I'm going to highlight 4 different ways in which things can go wrong. One I'll call abuse, injudicial use, injudicious withholding, and unskilled use. And I'll give examples of all of them. Abuse of palliative sedation is when clinicians sedate patients approaching the end of life with the primary goal of just hurrying things up. And this has been called slow euthanasia. And when I was an intern in Australia, I had a patient with a severe stroke, and my consultant asked me to start an infusion of morphine at 1 milligram an hour and to come back and to double the dose every 6 hours. And I asked him, I said, look, I really need to clear this with the Australian Medical Association before I can proceed. And he withdrew the order. But it's been well documented around the world that this is a real problem of doctors starting sedation without proportionality and very rapidly deeply sedating patients, primarily to hurry things up. And this it can be very harmful to the credibility of palliative care. And I've had one of the senior rabbis in the country saying that he would not he would not allow patients who consulted with him to go to a certain hospice because he said that they are killing patients. And this is the sort of image that we need to very actively avoid through judicious use and proportionality.
But Nathan, this happens regularly all over the place, in hospitals and at home as well.
Well, so it is our role. I mean, and commonly even in our department, we have this. I mean, someone will suggest, well, let's just we've had enough. Let's just deeply sedate the patient, and then the issue is, as palliative care experts saying, okay, if we're going to do this, we need to do this ethically, and it's got to be proportionate, and we're going to start with emphasis on due process, and if sometimes in our consultations we will see people who are saying, "Oh, can't you just sedate them to hurry this along?" Or with families saying, "Can't you turn up the sedation more?" So look, we don't do that. If the patient is comfortable, and this is part of the reason why I don't like leaving families with drips just being controlled with a drip counter. because sometimes it is the family members who are saying, this is taking too slow and they're not comfortable with it. And I think that that where possible, it is preferential to use pumps with appropriate safeguards rather than unsupervised infusions that are open to tampering with. Injudicious use is using palliative sedation with the intent of relieving symptoms, but in clinical circumstances which aren't appropriate. And then this primarily relates to inadequate patient assessment, where potentially reversible causes of distress are overlooked, or failure to engage expert clinicians. What is refractory is very much dependent upon the degree of expertise of the person who's making this judgment, and and around the hospital, certainly in our institution, we ask clinicians to consult with us before starting, and we try to give around the clock coverage, even if it can't be there in present first, at least to give a telephone consultation. Another injudicious thing is where you have either exasperated and fatigued clinicians, or exasperated and fatigued family members, pushing for more sedation than is necessary. Injudicious withholding of sedation is where you have excessive deferral of the use of sedation.
אני יכולה רגע להוסיף משהו על מה שאמרת עכשיו.
כן.
בצירוף לגם מה שהעירו קודם על כך שבאמת יש גם משפחות וגם שירותי בריאות שנוטים לזרז קצת לא כל כך קצת. יש משפחות שמבקשות, יש לפעמים מטופלים שמבקשים, ויש לפעמים שירותים מסוימים שמציעים. אבל אני כן רואה שמה שאתה אמרת עכשיו, המשפט האחרון של ה-family fatigue, הוא הרבה פעמים המפתח. אם אנחנו מורידים את הנטל מהם ומאזנים את הסימפטומים ובאים עם קצת נחת רוח, בדרך כלל הם לא חוזרים על הבקשה אחרי יום או יומיים, ולהפך הם מוצאים איזשהו זמן שהוא ממש ממש חשוב ומפסיקים למהר. נגיד שזה איכות טיפול, זה בעצם, אני לא רואה איכות גדולה בלעשות סדציה, לפעמים אין ברירה, אבל בדרך כלל זה מקרה של אין ברירה ולא הברירה הראשונה או השנייה.
נכון, זו אופציה אחרונה, וגם כן שהחולה כבר נוח, אנחנו צריכים גם כן לתת הרבה תשומת לב למשפחות במצב הזה, כי המצב הזה שהחולה איתנו אבל לא איתנו, זה זמן לא קל למשפחות, להסביר להם, אני מסביר להם שרצוי להחזיק את היד של החולה, לדבר לחולה אבל לא לשאול שאלות, להדריך אותם איך הם יכולים לעזור בטיפול של החולה, במיוחד בטיפולי פה, שמרגישים שאדם יש איזושהי מעורבות עם החולה. ששואלים אותי אם החולה מבין או שומע, אנחנו מאבדים את התחושות באופן הדרגתי. התחושות של ריח ומגע זה בין הדברים האחרונים לעזוב אותנו, וזה הסיבה שאני מעודד בני משפחה להחזיק את היד או ללטף את החולה, לא להתרחק אלא להיות קרוב, כי לכל אחד מאיתנו יש את הריח של עצמנו, שהחולה לא תרגיש מנוטש. ולהגיד למשפחות שגם כן, אתם לא צריכים להיות שם כל הזמן, אפשר לעשות רוטציות, זה כן מעייף רגשי, וחשוב לא רק להיות נוכח לחולה, אבל גם כן לשמור על עצמם בהתמודדות של עצמם. להכניס מוזיקה לסביבה, לרוב לא מדברים על יותר מיום יומיים, מדי פעם, וזה קצת יוצא דופן, זה הולך עד שבוע, אני לא זכור לי מקרים מעל שבוע. Injudicious withholding, זה שאנחנו נמנעים, excessive deferral of the use of sedation, whilst persisting with other therapeutic options that aren't providing adequate relief. בעולם האונקולוגי יש את הביטוי counterphobic determination to treat. You so much don't want to sedate the patient that you keep on trying other things that are just not working. So צריכים גם כמדי פעם להכיר שזה אכן מצב מאוד עמיד, ולא להמשיך להתעקש עם אופציות נוספות שהם כבר לא עובדים. Substandard practices. So here you've got appropriate indication, but without appropriate attention to processes that are essential to good care. So examples: inadequate consultation with the patient, family members, or staff members. If the patient and particularly the family members and other staff members don't all understand why this is being done, you can get issues of conflict or moral distress, and that's something which when a decision is made to start sedation, it should be a decision of the entire team with the understanding and support of everyone involved. Inadequate monitoring of symptom distress or the adequacy of relief. Inadequate assessment of the psychological, spiritual, or social factors that may be contributing to the patient's distress. So sometimes there could be a physical pain, but there may be other psychological things or social factors that can be addressed, and if those are addressed, that would make the patient feel better and less distressed. This is the concept of total pain. In a situation of respite sedation, inadequate monitoring of physiological parameters, inadequate care of the patient's family, and inadequate attention to emotional and spiritual being of distressed staff members. The issue of moral distress, in my department, one of the issues which is the biggest triggers for moral distress sometimes among staff members is palliative sedation. And looking after the emotional well-being of the staff is also really, really important here. And another example is inappropriate dose escalation without titration to effect, and not using minimal effective doses. That's another substandard practice. So just a couple of other things about the history. The first descriptions that I found, and I found these occasional case reports. These are from 1991 and 1992. Was a case report in 1991 by a guy called Dr. Enck. Robert Trug, who's a pediatric intensive care specialist, wrote an editorial in the New England Journal of Medicine about the use of barbiturates in the care of the terminally ill. And then it was in 1994 that we put together the first comprehensive guidelines describing the use and describing the criteria for defining what is a refractory symptom. And this is now, I mean, even though it was in a low impact factor journal, it's been cited almost 600 times. This is from that ruling of the Supreme Court in the United States, talking about the space permits physicians to alleviate anxiety and discomfort when withdrawing artificial life support or necessary medications that will hasten death further, and it permits the physicians to administer medication the patients in terminal conditions when the primary intent is to alleviate pain, even when the medication is so powerful as to hasten death, and the patient chooses to receive it without understanding. The first guidelines for existential distress we wrote in 1998. And then, as I mentioned, there have been two versions of the EAPC guidelines, the European Association for Palliative Care. The first one was a group that I led in 2009, and the revised framework was published last year. This was done by a large Delphi group where they took all of the assertions from the 2009 framework and put them through a review by 40 palliative care specialists around the world. And then they made multiple minor changes, really not very substantive. What's new in the 2023 guidelines, the issue of proportionality, the definition of refractory symptoms, emphasizing that it can also be from existential distress or from a cluster of symptoms, and that the determination of refractoriness is a joint decision between the physicians, the patient, and their legal representatives. The guidelines explicitly assert that the aim of palliative sedation is to relieve refractory suffering and not to shorten life. The imperative of documentation to be stored in a readily accessible and retrievable format. That's a documentation of advanced care planning. Consent should be adapted to the extent that the patient wishes to be informed. The section on pharmacological measures, they've got first line, second line, and third line drugs. And they give a number of different tools to evaluate patient comfort in the monitoring situation. Okay. With that, I'm going to conclude. But I'd be more than happy to open this to discussion, because I know, this is something which touches on all of our lives, and there are it's one of these situations where we can make the end of life care for very distressed patients that much easier, but also it is not without its controversies, and sometimes not without clinician discomfort.
אני מוצא שזה שאנחנו עושים את הגל הראשון זמני, או 6 שעות או 24 שעות, ההצעה הזו מרגיעה הרבה מהדאגות וההתנגדות של המטופלים או של המשפחה. בדרך כלל מישהו מהם רוצה והשני חושש או לא רוצה, אז הניסיון הזמני הראשון גם ממחיש לכולם שמתעוררים מזה, וגם מקבל איזה אישור לאחר מעשה. נכון, יש את המטופלים שלא רוצים אף פעם בכלל לקום. אני משתדל מאוד לשכנע שבאמת שתהיה השכמה אחרי או 6 או 24 שעות, ואז זה נותן לכולם איזושהי פרספקטיבה לגבי הפרוצדורה והתועלת שלה.
יש מישהו בין אנשים שמתעסקים במסגרת של בית? מייק?
כן.
אני, גם כן.
מייקל?
כן. אני רציתי לשאול אפילו אם, לאור מה שאתה אומר, אם יש השקפה שונה בבית, למשל, השימוש בעירוי בבית יכול לאיים לא על המטופל בעצמו, אלא על המשפחה לפעמים, אז טיפול אחות באינפוזיה של מידה זולה, ואולי לערב תרופות אחרות בבית, שבכל זאת נותן סדציה, אמנם בלי המיידיות של טיפול במידה זולה, ריבוטרילים, מורפיום או משהו.
לחולים שקיבלו הרבה אופיואידים, לפני כן, מורפין אינו תרופה טובה לסדציה. Because they get tachyphylaxis to the sedating effect of morphine, and if you increase the dose, they get the neuroexcitatory, so you get more delirium and myoclonus, and less sedation. So we generally discourage the use of opioids for controlled sedation. And I think that with patients who've got either issues of severe delirium, pain, or dyspnea, you know, even to have a range of drugs in the house, including midazolam if it's needed, is very appropriate. Because you don't, particularly in remote settings, because the last thing you want is to be in a situation where you've got someone who's very distressed, and you don't have the tools at hand to be able to provide adequate relief. So in Australia, it is actually common practice when patients are discharged home during hospice, the families are given a box. They call it a hospice box, which has a whole range of medication in adequate supplies, including midazolam, morphine, haloperidol, olanzapine, to have in the house if needed. You know, that's not for the, so it's not for the family to administer unsupervised, but for anyone coming in the house providing care, it means that they've got medications and inappropriate doses in the house without having to worry about trying to urgently procure medicines in an urgent situation.
We do that too in hospice גליל עליון, ומה שאנחנו גם עושים בכל בית.
כן, אני לציין גם את האפשרות של התייעצויות וידאו, כאשר יש למשפחות את 5 התרופות, ואנחנו מסבירים להם מראש מה כל אחת עושה, אז לפעמים בהתייעצות וידאו אפשר, בעיקר עם התרופות התת-לשוניות, אז נאמר, מדבקת פנטה וריבוטריל יכולים ממש להביא אדם לסדציה נחמדה, אבל גם עלולים לגרום לו לדליריום, אז אני מקפיד שיהיה להם גם באמת הלידול בבית, והמשפחות מרגישות די בנוח לתת טיפול תת-לשוני בהדרכה שלנו מרחוק.
מידזולם זו תרופה מאוד מאוד נוחה למתן תת-עורי, שמאוד מקובל בבית. אנחנו בהוספיס מעדיפים גם באשפוז את המתן התת-עורי על פני המתן IV. אנחנו מוצאים שהספיגה היא טובה, אין צורך בדיוק על המילימטר, דרך משאבת מזרק, גם בבית זה משאבות קטנות שהיום קופות החולים מספקות, אפשר לתת באופן תת-עורי מידזולם לסדציה באמת טובה.
מסכים.
אני דווקא מוטרד מחוסר הזמינות של נוזינן בבית, זאת אומרת, הלידול, היא לא תרופה מאוד מאוד סדטיבית, ואנחנו לא משתמשים בה לסדציה, ויש הרבה סדציות שמידזולם לא מספיק, ואנחנו נאלצים בבית החולים להשתמש בנוזינן בכמויות גדולות, ולפעמים אפילו קורה לנו כמה פעמים בשנה להשתמש בפנוברביטל, ואז אני תוהה עם אנשי הבית שנמצאים פה, איך אתם מתמודדים עם סדציות שמידזולם, שכבר מגיעים למינונים של 5 מיליגרם לשעה ויותר, אנחנו יודעים שיש גם אפקט הפוך לפעמים, אז איך אתם מתמודדים עם זה? והאם לא הגיע הזמן שאנחנו כקבוצה נלחץ על הזמינות של זה בבית?
מה הזמינות של נוזינן בבית?
אין.
זה רק בבית חולים?
כן, אני תמיד תוהה איך מסתדרים, כי בבית חולים הרבה פעמים זה לא מספיק.
מה עם לארגקטיל בבית? יש לארגקטיל? כי זה גם תרופה
אפשר רק IV. לארגקטיל אפשר רק IV.
בין החולים האונקולוגיים, כמעט רובם יש venous access device, זה לא צריך להיות בעיה.
אני אשמח לדעת...
ולגקטל יש גם כן בנרות.
אני אשמח לדעת איך אתם מצליחים להשיג נוזינן IV או תטורי, אפילו בבית חולים אנחנו מתקשים, והייתי שמח שהיא גם כמובן בקהילה, אבל גם בבית חולים. אז אם יש לכם כתובת איפה להשיג, אנחנו נשמח לקבל בהר הצופים פרטים על זה. נוזינן תרופה מצוינת. לא, משתמשים לנו, יש רק בכדורים למשל, ועובד מצוין בהרגעה ובסדציה, לא בסדציה פליאטיבית בסוף החיים, כי בסוף יהיה אפשר לבלוע כל הזמן, אבל אם היה אפשרות לקבל תטורי, אז זה היה עוזר מאוד דווקא במקרים שדור מיקום לא עושה את העבודה.
אנחנו משתמשים סבקוטן בדרך כלל בנוזינן, וגם לפעמים IV, אבל לרוב סבקוטן באוסטן.
אז התרופה קיים, אז אולי דני לבקש מהבית מרקחת שלך, להיות בקשר עם בית מרקחת בשיבא, לבדוק איך משיגים את זה.
אני אשמח להעביר את הפרטים של הרוקחים אצלנו, למי שצריך, אבל אני חושב שגם בקהילה, אני לא יודע, יש פה אנשי קהילה, אני אשמח שיתייחסו, כי זה נשמע לי ממש בעיה.
אין, לא מצאנו.
אני בקהילה זמן קצר, אז עוד לא, אין לי ניסיון, אבל ב6 שנים באיכילוב במחלקה פליאטיבית לא הגענו לצורך בנוזינן. מקרים נדירים שהשתמשנו בקטמין לסדציות בעייתיות.
אני רואה שאולגה פה, שלמי שלא מכיר את האולגה, עשתה עבודה נפלאה על הסקר של בני משפחות אחרי האירוע של בן משפחה שנפטר אחרי סדציה, על החוויה שלהם. אולגה, את רוצה להוסיף כמה מילים על העבודה שלך?
קודם כל אני מודה לך על העזרה וההנחיות בעבודה, ומה שאני לקחתי מהעבודה הזאת, שלהסביר למשפחה מה זה סדציה פליאטיבית, למה עושים את זה, לא לפני שחולה התחיל טיסה, אלא חודשיים לפני, מאוד נותן זמן לאבד את האינפורמציה, להתייעץ עם מטופל עצמו וליישם את זה. וקיבלנו מאוד תודות מהמשפחות, ואמירות היו שאף אחד לא סיפר קודם, ורק במחלקה שהגענו התחילו לדבר על זה. אז מה שאני רוצה להעביר מסר, שאולי שמדברים על הנחיות מקדימות, או על טיפולים בסוף, להגיד על זה, לספר למשפחות שלא יפחדו שאם יגיע רגע קשה, שיש סדציה פליאטיבית. נראה לי זה חשוב, וזאת הייתה מסקנה מעבודה במחקר אצלנו, שההסבר מוקדם מאוד מרגיע מטופלים.
תודה.
תודה לך.
אני רק רוצה להציף איזה עניין שאני נתקלתי בו, שאני חושבת שזה לא, אין לנו עוד זמן לדיין את זה, אבל אולי בהמשך או בהזדמנות אחרת. אני חווה בעיה מאוד קשה במחלקות הפנימיות. מבחינת הגישה שלהם לסדציה פליאטיבית. אני חושבת שהם לא מגדירים לעצמם מה הם עושים, ובעצם משתמשים באמת בדריפ מורפין במקום כסדציה פליאטיבית.
ואפילו קוראים לזה, אנחנו נתחיל דריפ מורפין, וזה באמת מסכים.
תודה רבה. תודה רבה פרופסור צ'ני, תודה לכל המשתתפים על ההרצאה הזו, ושנזכה להמשיך ולהיטיב בכל שלב.
תודה רבה.
תודה רבה.
תודה רבה.
תודה רבה.
תודה רבה.
תודה רבה. דניאל אזולאי.